everyone. Thank you very much for joining. We are waiting for Dr. Durawade, who was finishing up her last procedure of the day. So she's running a few minutes behind. But as we wait for her, I'd like to give you a brief introduction of her bio, and then we'll just talk a little bit about what we are going to be doing this evening. Throughout today, if you have any questions about anything that we're discussing, feel free to type your question in the chat and we will be sure to address those. And you could do that at any time throughout the webinar. You don't need to wait until the end. You could just type into the chat and we will be happy to answer those questions for you. So I'm going to just tell you a little bit about Dr. Durawade so you know all about her when she joins. I'm sure some of you are existing patients and some are potential new patients that are interested in seeing her for a consultation. So she is a board certified OBGYN who's been practicing in the South Suburban area of Chicago for the past 5 years. She got her degree in biochemistry and molecular biology at Illinois State University in 2009 and went on to obtain her MD at the University of Illinois College of Medicine, followed by residency in obstetrics and GYN in Ann Arbor, Michigan. She returned home to the South Suburban area of Chicago to provide personalized care to the women she wanted to serve, women she could relate with, and those whose issues resonated with her. Dr. Durawade's passion is transforming the lives of the women she serves. She strongly believes that women should thrive at every stage of their life. She is invested in helping women look and feel their best at any age, and she is intentional about educating her patients regarding their conditions and providing them with an array of treatment options. She opened her own private practice in order to achieve this goal. Dr. Durawade also created a show titled Uncommon Knowledge on her YouTube channel to further educate her patients. On the show, she shares information that should be common but remains largely uncommon with her subscribers and social media community at large. Dr. Durawade enjoys traveling, spending time with her family, and watching K-dramas. And there she is, right on time and right on cue. So welcome and thank you for joining us.
Thank you. Thank you so much for having me. I was hoping to be made up and pretty looking and, you know, lipstick, but I couldn't work it. So accept me as I am.
You look amazing. And I'm sure the patient that you took the time to take care of just now appreciates you doing that instead of getting fancy for us.
Fancy.
Yes.
Thank you for having me and thank you for a lovely introduction.
Absolutely. So I just told our attendees that if they have questions throughout the webinar, they could just type them into the chat and we'll be sure to address those. So I will just pause you if I see a question come in and read it through to you as you can go through the slides, but I'm going to turn it over to you and we will get started with your presentation.
Okay, sounds good.
All right. Thank you.
Regardless of whether or not you're always all done up with your lipstick, your glasses are always so fun and like the best accessory.
Thank you. Thank you everyone for joining me today. I'm really excited to talk about this today because I see a lot of women every day. And the main concern is fibroids, heavy periods, painful periods. And so there are a lot of innovative ways to treat fibroids, to treat heavy periods. And we're just looking for the best, the brightest, the least invasive that can help you return back to your normal life as quickly as possible. So I'm excited to talk about this today. We can go to the next slide. So this is the story of about 7 women who underwent the procedure and what their lives were like before the before the Sonata treatment and after the Sonata treatment. It's about a 4-minute video, so we'll just go ahead and play it so you can listen to the video.
Most fibroids are asymptomatic or without symptoms. For the women that do have symptoms, the symptoms are heavy menstrual bleeding, low pelvic pressure. You could have problems with urination, constipation.
I first started having symptoms about 7, 8 years ago. In my early 20s, probably 8+ years ago, 4 years ago. When I first started my cycle at age 14, and they were always horrible.
And some of the stories that women have communicated to me have been otherworldly. They really modify their whole lifestyle as a result of their symptoms.
My symptoms got so bad that I actually had to change careers because I could not continue taking days off of work because I couldn't get out of bed. My symptoms were so bad to the point I would be in the house a week straight. It was essentially having my period all month long.
When I was taking sick days because I just couldn't get out of bed, painkillers were not helping. I don't remember a time when fibroids didn't affect me.
My doctors told me that the best treatment would be most likely a full hysterectomy to treat this.
They offered me birth control pills to help with the bleeding. I went to several doctors looking for an alternate opinion, and I consistently got hysterectomy being my only option.
Hysterectomy or myomectomy, I believe, is the other option she gave me.
A hysterectomy was my only option.
A hysterectomy. And then they suggested I could take some birth control pills.
Minimally invasive hysterectomy, your recovery is 3 to 4 weeks. If it's done open, it's a 6 to 8 week recovery.
I thought a better option would just be to deal with the symptoms than to have my body parts removed. There were not any treatments for it.
The Sonata treatment is for women with symptomatic fibroids who want to preserve their uterus and avoid major surgery.
After my Sonata treatment, I saw relief. I wasn't having constant periods every single day.
It just started getting lighter and lighter.
I say about a 75% reduction from what I was used to. I do not suffer from the pain, the cramping, or the heavy bleeding like I did prior to the Sonata treatment.
I don't have to worry about going anywhere when I'm having my period. I don't have to worry about if it's gonna be an incident like before.
The procedure takes less than an hour typically. Recovery is a half hour to 45 minutes before you're discharged and ready to go home.
I no longer have to carry an extra change of clothes. I don't have to keep anything on my mattress.
You have a chance to actually have this treatment and know that your life can be so much better.
Absolutely, hands down. Investigate it, check it out. I would look at it as a first option. I know this sounds weird, but I can wear white pants and not be nervous about it. I would definitely tell them to try the Sonata.
The Sonata treatment is very effective. 95% of the women have a reduction in menstrual flow after 1 year, and 97% will recommend it to a friend.
Look into the Sonata process.
Just give it a chance.
It's a game changer.
I never got to wear tampons before. I can wear tampons now. I believe it's the way to go.
All right. So I feel that a lot of my patients can relate to the stories of these women. I've heard the same stories over and over again myself from my patients when they come. You know, their symptoms are mostly the bleeding, the painful periods, and just the pelvic pressure. Sometimes they're going to the bathroom 3 times within the time that we're together. And so half the time, what we're doing after they explain their symptoms is an ultrasound. And so the ultrasound usually identifies some type of fibroid. So what are fibroids? We can go to the next slide. Fibroids are tumors, but they're not cancer. So anytime people hear tumor, they kind of are a little bit alarmed, but 90% of the time, fibroids are not cancer. There are some that can be, but it's very rare. And so there are tumors that grow in the body of the uterus. If you look at the right of your screen, you see the picture of the uterus, and you see those yellow round pictures. Those are the tumors within the body of the uterus. So if you think of the uterus like it's a balloon, you have the outside that has the fibroids, and you have the inside where the bleeding comes from. And so you would have fibroids that are either big or that are small, fibroids that are on the inside or fibroids that are on the outside. We can go to the next slide. So we'll be going back and forth between this slide and the previous slide. So fibroids usually cause pain or heavy bleeding, pelvic pain or heavy bleeding. Sometimes it causes bowel issues, bloating, bladder pressure as well. So depending on where they are and how big they are. So the first one are submucous fibroids. We can go back to the previous slide. I want to show what a submucous fibroid would be. So if you look at the inside, if you can put your mouse into the cavity of the uterus, yes. So if a fibroid was inside that location, that is a submucous fibroid. That is a fibroid that is inside the cavity where our bleeding comes from, where our period comes from. So women who have fibroids in this location bleed very heavily during their periods. They're passing large clots. It's almost, they're soaking through their clothes. I mean, I have a patient who, whenever her period is coming, has to take an extra change of clothes in her trunk. And sometimes she's a teacher, so during lunch break at school, she will rush to the trunk, grab her clothes so she can change. I mean, that's how heavy the bleeding can be and how disruptive it can be to your life. We can go to the next slide. And then you have intramural fibers. Those are fibers that are within the body of the uterus. So let's go back to the previous slide. Now, yes, where we're pointing, that's where those intramural fibroids are. And those can get pretty large. They can be as large as a medium-sized orange or as large as a cantaloupe. They can make the uterus very, very big. So those are what we call intramural fibroids. We can go to the next slide. And those usually kind of cause bloating. Like I said, it can be as big as a cantaloupe. So they can push on the bladder, making the bladder irritable. You're peeing 5 times in 1 hour. Also can make your periods very heavy. The last one is the subserous fibroid. We can go back to the previous slide. Subserous, yes, that's the one that's kind of on the outskirts on the of the uterus. Now, depending on how big they are, they can really cause a lot of pelvic pain. You know, if you have a fibroid on that side that's as big as, let's say, cantaloupe, or even sometimes I've seen one as big as a watermelon, that will be pushing on all the other organs in the pelvis. Your uterus should be the size of your fist. These fibroids make the uterus enlarge, so that it's taking up space. It's affecting the bowels, the bladder. You're bloated. You're peeing frequently. You have pelvic pain. It's pushing on nerves. You have pelvic pain. So that's how most people end up coming to the doctor, like they have this pain constantly or this pain during their periods. And half the time when I do an exam, I can either feel the fibroid, or when I do an ultrasound, I can identify the fibroid. You can go to the next slide. All right, we talked about the different types and how they can affect you. Now, in the US, nearly 70% of Caucasian women and more than 80% of African American women will have uterine fibroids before the age of 50. What does this mean? It means that 1 in 2, if there are 2 women here standing together, one of them has fibroids. That's what it means. Or if there are 3 Caucasian women standing together, one of them has fibroids. And so before the age of 50, because a lot of people are still having periods before the age of 50, so they will come to the doctor and say, my periods are weird. And that's how we can sometimes diagnose it. About 20 to 50% of these women will have symptoms. Now, there are people who have fibroids that don't have any symptoms. I did an ultrasound on one of my patients yesterday, and she had the subserous fibroids, so the ones that are on the outskirts. She had no symptom. We're doing an ultrasound for something else, and we're like, oh, by the way, we were doing an ultrasound for our ovaries, but then we saw the small fibroids on the outside. So there are some women who have fibroids who don't have symptoms, but about half of the women with fibroids will have symptoms. And more than 2 million women in the US undergo treatment for fibroids every year. Now, this is an important one. If your mother or your sister has fibroids, your chances of fibroids are also higher. It runs in families. It's hereditary. We still don't know what causes fibroids. We are still, in search of what causes it. There are lots of ideas about what could increase your risk of it. Some people will say low vitamin D. Some people will say different things can cause fibroids, but we think it's more genetic. It's more a genetic link. So if a mother has it, a sister has it, most likely that woman will likely have it as well. We can go to the next slide. Fibroids are often suspected on a routine pelvic exam. And this is what I tell women that I meet, that I hope you're getting your pap smears with a gynecologist. It's okay to do your pap smears with your primary doctor or with your regular doctor, but that doctor also has to be doing what I call an internal exam. That internal exam is to feel the uterus. So every time I do your exam, I see you for a consultation, and I do a physical exam. I am doing an internal exam, meaning a finger inside the vagina, a finger on top of your belly to feel the size of the uterus. Most of the time, that's how I diagnose fibroids. There are people who are like, oh, my periods are heavy, but it's always been that way. It's never been a problem for me. Even though I soak through 5 pads a day, that's kind of how it's always been. And so by the time I do an exam, I'm like, your uterus is enlarged. You most likely have fibroids. So in my practice, I would say 90% of the fibroids I diagnose are based on physical exam. And that's when I now move to an ultrasound. So, just feeling it may not be the definitive, especially if we're going to do some type of treatment. I like to do an ultrasound to see where it is. Is it on the outskirts? Is it on the inside of the cavity, or is it in the body of the uterus, like we talked about? And so if you are having heavy bleeding, your periods are longer than 7 days. If you're having 10 days of periods, that's not normal. If your periods are disrupting your life, I always tell my patients that your periods should not control your life. It should just be something that happens. It shouldn't be like a whole drama around it where you're carrying extra clothes, extra pads. You're getting anxiety when your period is coming because you're afraid you might have an accident. If you have an important meeting going on, you're worried, you're packed. That should not be how your periods should be. Okay. Next slide, please. Oh, this is why this webinar is titled, It's Time to Take Care of You, right? Because women will, they'll eat after everybody else is in the house as eaten. They'll go to their own appointments last. So they don't even schedule their own appointments. They'll schedule their husbands, their children. They'll attend all those appointments, but then kind of reschedule their own or kind of push it off. So a lot of women wait an average of 3.6 years, before, or more than 5 years before evaluating their own symptoms. It's when it becomes a real problem that they're like, you know what, maybe I should go to my doctor to get this. And I always tell my patients that, yes, you care for everybody else. Well, I'm here to care for you. And so that's usually how it happens. People have been dealing with those symptoms for a while. If you check in that video that we watched at the beginning, a lot of people had the issues for 8 years. They had the issues for 4 years. There was a lady there that said it's been since she was 14 years old. So she's been going through it. So before most women seek treatment, it's usually around 3 to 5 years. And a lot of women do not want a big surgery. That video, a lot of women were saying that they were offered hysterectomies. They were offered, a full hysterectomy to have their uterus taken out. So a lot of women just want something simple that won't disrupt their lives, that they don't have to take off work, so that they can just stop worrying about their periods. And so in my practice, I would say about 50% of women want to preserve their uterus, meaning they want to keep it. They don't want to take it out. Next slide, please. And so what are the treatment options? I'm sure if you were here at the beginning, you probably heard the stories of these women. They were offered different things: birth control, myomectomy, hysterectomy. So we can go over the different treatment options that I offer my patients. Next slide. Yes, you do have choices. If you have heavy periods, there are multiple choices, multiple ways to get you to your goal. Next slide, please. All right, so common treatment. So I don't know if you were present at the beginning, you would have heard them say, I was offered birth control pills. So that's the medical treatment. And then the second one, most common one, is a myomectomy of the inside of the cavity. Remember, we talked about different types of fibroids. The submucous one is the one that's inside. If you could put your cursor right in the center of the submucous fibroid, yes. So a fibroid that is inside the balloon. If you think of the uterus like it's a balloon, the balloon has an inside, the fiber that's inside there. When we shave off that fiber, that's called a hysteroscopic myomectomy. There's another treatment option that I actually offer a fair amount. It's called uterine artery embolization. That's when we block the blood flow going to the fibroid. I'll talk about these in more detail in the next few slides. And then the laparoscopic or open myomectomy is when we actually make an incision in your belly, go to the uterus, make an incision in the uterus where the fibroid is, take out the fibroid, and sew the uterus back up. So each side the fibroid is in, we make an incision there, kind of pull the fibroid out, sew up the defect. And then the hysterectomy, everybody knows about a hysterectomy, where we take out the uterus so you never grow the fibroids again. Next slide, please. All right, medical treatment. So birth control pills can help heavy bleeding, right? Birth control pills are not going to shrink the fibroid. They're not going to make the fibroids disappear. They're just going to control the bleeding and make the bleeding less heavy. And in some women, the bleeding is still heavy. It's just not as dramatically heavy like it used to be. And then the other options are these medicines that kind of reduce the amount of estrogen your body's experiencing. It's there. I don't know if you've heard of it. You probably have heard some commercials. There's the Orion, there's Orlissa. What they do is they reduce how much stimulation the fibroid is getting from your hormones. And in some cases, there was one medicine we used to use a little while ago called Lupron. You might have been offered this by your doctor as well. Lupron basically puts you into menopause so that the fibroids are not stimulated, because fibroids grow in response to estrogen. So the more estrogen your body has, the more the fibroids will grow. And so that medicine kind of puts you in menopause, stops your estrogen so the fibroids don't grow. But then you have all the bad symptoms of menopause, your hot flashes, night sweats, you can't sleep, you're uncomfortable, you're moody, you're tired. So those treatments, people can't stay on it for long. Right? So those are some of the common treatments that people end up looking for a different option, even after being started on those. And you know, like I said, they don't take the fibroids away. So once you stop taking the birth control pills, you return to how you used to be. All right, next slide, please.
And Dr. Durawade, a question that we get often about the medical therapy is that a lot of times women think that the fibroids do not grow at all while you're on medical management. And so we'll hear women are surprised that their fibroids increased in size sometimes. Can you speak a little bit to that?
Yeah, absolutely. So remember, fibroids respond to estrogen. Your birth control pill does have some hormone in it. You know, and sometimes when you're taking birth control pills, if you're not as consistent as you need to be, your body will release its own estrogen. And so fibroids kind of will continue to kind of grow. There was a patient of mine where, you know, even though she was on birth control pills, just like you said, Tara, the fibroid just would not kind of relent. It seemed more like an angry little toddler that just wanted to get its way. And so the birth control pills are for bleeding. They don't really address the fibroids. The other medicines to kind of put you into menopause might help with the growth of the fibroids. Remember, they respond to hormonal stimulation. So if I give you a medication that puts you in menopause, meaning no hormone stimulation, then that might kind of stop them where they are, but it won't shrink them, right? And sometimes if you then choose to have surgery, then the medicines may have made the fibroids a little mushy, and then it's hard for us to take them out. So they kind of create their own, everything kind of has its ups and downs. But some people who are like, they don't have time for anything else, birth control pills is a temporary solution for the bleeding, not for the fibroids. Next slide, please. Hysteroscopic myomectomy. Now, I talked about this a little bit. So this one, there's no incisions on the uterus. We kind of go in like we're doing a PAP, but we're not doing a PAP. But we kind of act like we're doing a PAP. So it's done vaginally. And then we put this medicine into, we put the device into the uterus, into the balloon. Think of the uterus like it's a balloon. I put the device into the balloon. And then there's a little thing that allows me to shave the fibroid off. Only disadvantage of this is that it can grow back. You know, there was a patient who maybe a year ago had this procedure done, and literally a year later, it grew back to the same size. If there had been no pictures the first time around, she would have said, "Doc, you did not take out the fibroid," because it grew back exactly the same size, the same way. So that's the disadvantage of a myomectomy. You can take off the whole fibroid, you can take it off whole, you can shave it off, but there are microscopic cells left behind that can start forming back again. And that can happen as soon as 1 year, or some women as 5 years. And this is only for fibroids inside the balloon. Sorry, yeah, you can go to the next slide. Uterine artery embolization. I actually do offer this a lot in that, you know, it does require an incision. They go through the groin area. The incision is quite small. They go through the groin area. They're going to do it under CT scan. What they're looking for are the blood vessels that are going directly to these fibroids, and then they block off those blood vessels. Now, there is some evidence that the fibroid might shrink a little, but not significantly. Maybe it shrinks 20%, 30%. If I were to measure the size of the fibroid before the uterine artery embolization, maybe it was 7 centimeters. And then after, maybe 3 months after the uterine artery embolization, maybe it's like 6 centimeters. So it doesn't really shrink it the way we think of in terms of shrinking, but it makes a big difference with bleeding. A lot of people either don't have any bleeding or they have their periods, but it's much lighter. Sometimes you stay in the hospital, depending on if you have a fever or not. If the fibroids are very big and then you block up their blood flow and they start dying off, the pain can be severe. The last time I had a patient in the hospital, we did this for 8 centimeter fibroid. I kept getting calls over and over again because she was in so much pain because the fibroid was dying off. And that's because it was a larger fibroid. So like I said, everything has its ups and downs. And this will treat the current fibroids. It does not prevent new ones from growing. You know, the uterus can have new fibroids manifesting in different places. And 30%, studies show that 30% of the people who have this procedure end up needing another kind of procedure in about 5 years. Next slide, please. Laparoscopic or open myomectomy. So this one, I feel that the patients that choose this one choose it for like pelvic pressure symptoms, you know, where the fibroids are really big, causing pain and pushing on things. And, you know, they're like, the idea of something in my uterus just freaks me out. I just want it out. And so we would have to do an incision on the belly. We can do it laparoscopically, so with a tiny incision, and then we use little instruments to make an incision in the balloon, take the fibroid out, and then sew the uterus back up. So the uterus will have stitches in different areas. With a myomectomy, you can take out the whole fibroid, but there might be cells we cannot see with our eyes that make them form again. Actually, a lot of women within like 5 years, their fibroids grow back. Their bleeding goes back to how it used to be. Their bleeding will improve immediately in the immediate period of time. But let's say you see them 3 years later, they're like, you know, my periods are kind of going back to how they were before I had the myomectomy. And then we do an ultrasound and we find that the fibroids have come back. Depending on if you do it laparoscopically or open, we're doing like a C-section type of incision, lifting the uterus out of the pelvis, making an incision, taking out the fibroid, sewing it up. That one, about 6 to 8 weeks, is like having a C-section recovering. The laparoscopic one, maybe 3 to 4 weeks to recover. Either way, it is a disruption of your life. You have to take time off work. You have to take FMLA. You have to recover. You have incisions. You're going to need pain medication. You're going to be under anesthesia. So lots of things to consider. You know, this conversation usually take like 30 minutes when I'm trying to tell my patients the different treatment options available to them. Next slide, please. And then a hysterectomy. Hysterectomy is just removal of the uterus. Hysterectomy does not involve removing your ovaries. A lot of patients ask me, so if you take out my uterus, does that mean I'm in menopause? It actually does not. We say that menopause is stopping your bleeding, but it's actually decline of your estrogen. Menopause is literally your estrogen is going down, and so your uterus doesn't have a lot of stimulation, and then your periods go away. So if I take your uterus but leave your ovaries, you still have normal estrogen, so you are not in menopause, right? I just took the house. The uterus is just a house for your babies and for your periods. You're done having babies, you're done with periods, we can just take the house, leave your ovaries, which you still need the estrogen for your lifetime and stuff like that. But it's a major surgery, right? If you change your mind that you want to have kids later, the chance is gone because the house is gone, you know? You might need to stay in the hospital. If we do it laparoscopically with the robot or open, you might need to stay in the hospital overnight, 6 to 8 week recovery. And yeah, it's so final. A lot of women, there's some women that are ready for it, but there are some women that are just not ready to have that option completely off the table, option of having children completely off the table. But these are common treatment options that doctors will offer their patients. And if you watch that video at the beginning, you would notice that a lot of those patients were offered hysterectomy as an option. Next slide, please.
We do have a few questions that came in. For the hysterectomy, something that we hear pretty often during these webinars is that women think that when they have a hysterectomy, they go into menopause. Can you speak a little bit to that? And then there are a few questions in the chat I'd like to read to you also once we're done.
Right. So menopause naturally is the stopping of your periods. But that stopping of your periods happen because your ovaries are no longer making as much estrogen. So ovaries are really the ones that control menopause. So if your ovaries are left behind, and all I do is take your uterus, the uterus, like I said, it's just your house, a house for babies, a house for periods. If I take your uterus, but leave your ovaries, then you are not in menopause because your ovaries will still be making estrogen. So when you think of menopause, you think stopping periods, hot flashes, night sweats, all that. So we can stop the periods, but you won't necessarily have hot flashes or night sweats because you still have your ovaries. I hope I'm making sense. The ovaries control estrogen. Estrogen gives you periods. But if I take the uterus, the house that gives you periods, you won't have the periods, but you still have your estrogen. So you're not in menopause. Does that make sense? Did that make sense? I hope I'm making sense. So a hysterectomy does not necessarily put you in menopause. If we take your ovaries, then that puts you into menopause because then there's no source of estrogen. Remember, estrogen is what gives you periods. If you still have your estrogen, you're not in menopause. If I take your house, but leave your ovaries, you're not in menopause. You won't have the periods anymore because the house is gone, but you won't be in menopause because you still have your ovaries and your estrogen. I hope that makes sense.
Yes. So one question in the chat is that, are there any natural remedies to stop the growth or to not get them at all? A change in diet?
I get this question a lot. I wouldn't say that I know of any natural remedies to prevent fibroids. Like I said, we're still researching what causes them. We kind of have to know what causes them before we know how to prevent them. All we know so far is that they're genetic and they run in families. So we would say, any external stimulation, any estrogen stimulation. But birth control pills have not been shown to grow fibroids. We just know that they don't shrink them, and they don't really affect them. They just kind of regulate your bleeding. And so that's a very a tricky question in that I can't tell you for sure, yes, if you do this, they won't come, or if you do this, they will shrink. There's no evidence that you might find stuff on the internet, but there's no studies that say if you do this, this will happen. If you eat this, your fibroids will go away. There is no study like that. So it's kind of up in the air what natural ways are available. Like I said, if we know what causes them, we can probably know how to prevent them. For now, we're still kind of just treating them. We don't know what causes them.
Is it true that once you're in menopause, the fibroids will stop growing? Will they disappear?
They don't disappear. That's a tumor. It's fully formed, but it's possible they'll stop growing because you don't have that stimulation of estrogen. Remember, estrogen comes from your ovaries, stimulates your uterus with estrogen. Estrogen comes from your ovaries, stimulates the uterus. Then the uterus produces periods. So if you're in menopause, your ovaries are not making estrogen. There's not as much stimulation of the uterus. The fibroids are not really stimulated. Your periods stop. They don't really grow, but they don't shrink and they don't go away. If they fully form, they remain that size. So if maybe you're in menopause, but the fibroids are causing pain, then that's an opportunity to do one of these procedures or the Sonata procedure that I'll talk about in a little bit.
This is sort of along those same lines. So can I opt for the option that has them growing back when I am 44 because menopause will take care of me before they grow back?
That's a fair question. And I have people choose that option. Like, I'm almost into menopause. We can just take them out and hopefully they don't grow back before I get into. But I tell them it's not 100% guaranteed. You can definitely try it. We can hope that they don't grow back before your ovaries kind of decline and don't give as much estrogen stimulation. That's a fair option. That's a fair route to take, but there are better ways to prevent them from coming back.
Okay. And then I have a 1.1 centimeter mural fibroid from an ultrasound. Is that big? Also, I have a 6 millimeter polyp in the endometrium. Can you treat cervical polyps too?
1.1 centimeter is like the size of a grape. So no, that's not big. We're talking size of ping pong ball, baseball, large orange. I've taken fibroids the size of a watermelon out, like the size of a 30-week uterus out. So 1.1 centimeter is like the size of a grape. So we don't consider that. It's heavier than a grape, obviously. It's solid. So I would not consider that big. Cervical polyps are like fluffy tissue. So no, this does not treat cervical polyps. Those can be kind of taken off in the office or in the operating room. This will not be, this treatment we're talking about for solid tumors. Polyps are not tumors.
And then we touched on this a tad, but do you know or research that is more in depth about finding the root cause of fibroids, for example, hormonal imbalance? And then another woman said it feels and sounds like a curse that no one wants to research.
It is being actively researched. When I was in residency, we had this amazing doctor from Harvard come and talk to us and give us a lecture about the kind of research they're doing to try to figure this out, because it is so prevalent. It is so common. A lot of women suffer from it. And like I said, before women even seek treatment, it's 5 years down the line. They just kind of adjust their lives to fibroids. And so, yeah, it's definitely, I can find the Harvard studies that have been done on fibroids themselves and what causes them. What we know for sure is that there's a genetic predisposition, meaning your genes make it more likely for you to have it. And nobody really has control over their genes. Next slide, please. Yes, I'm ready to go to the next one. All right, to the fun stuff. All right. What is the Sonata treatment? Next slide, please. So I just did 2 Sonata surgeries today. That's why I'm here in my scrubs instead of fancied up like Tara and the other ladies. The Sonata treatment, I've been hearing about it. I've been seeing it. I've been reading about it. And then, when Angela from the Sonata company came to my office, I was like, oh, yeah, I've been meaning to talk to you. Like, almost like we were meant, almost like I'd known her before, but what I really knew was the Sonata procedure. Even my front desk person was like, oh, you were much nicer to her than all the other reps that have come to your office, because I was interested in the procedure. So the Sonata treatment is now available, and it treats a wide range of fibroids. And that's what I like about it. There's no fibroid that's too big for it to treat. Remember the uterine artery embolization, where they block the blood flow to the fibroid? If the fibroid is too big, it can cause a lot of pain as that fibroid kind of dies off. But we don't see that situation with the Sonata. There are no incisions, so we go vaginally. You remember that I was talking about the hysteroscopic one where we go vaginally. So no incisions on the belly. You don't have to take time off work or take pain medicines to recover from it. You don't have to get the uterus taken out. You don't have to have any incisions on the uterus itself. You don't have to stay in the hospital overnight. I would do it under general anesthesia, kind of put you to sleep. I wouldn't try to do it any other way, but there are people who do it like under kind of sedation. There are people who do it under sedation instead of general anesthesia. But that's how convenient the procedure can be. Next slide, please. All right. So this animation here kind of shows, I'll kind of walk you through what we do. The Sonata device kind of looks like a wand, kind of looks like a long wand. So this is how the patient is positioned in the operating, just like we're doing a pap smear, like you would be in the office, you would be positioned like you're about to have a pap smear. And that's the wand that goes inside the uterus. And I rotate it from 3 to 9 to identify the fibroids. So it's like an ultrasound. If you look to your bottom left, that's the picture I see. So that's the picture I see when I put the wand inside the uterus. It helps me to identify the fibroid on ultrasound. And they're usually round and circumscribed like that. So they're usually easy to find. And so what we're doing now is I'm gonna pass this red and green zone up into the fibroid so I can capture the entire fibroid. See how it's getting bigger? I want to get the whole fibroid into the red zone. So I make my circle bigger until I can get the entire fibroid in my red zone. The green zone is a safe zone. And then I pass this needle inside the fibroid so I can stabilize the wand in the fibroid. And that way my needle does not go anywhere else in the uterus. It doesn't go to the bladder. It doesn't go into the muscle of the uterus. It just stays inside the fibroid itself. And all this I'm doing while I'm looking at the ultrasound picture. And next thing I do, I pass the laser prongs. So those are the prongs that are going to deliver the laser energy. So I pass those prongs into the fibroid. So the initial needle is to stabilize the probe inside the fibroid, and then the prongs are to deliver the laser. And then I press my foot pedal, and that delivers the laser energy into the fibroid. And it's making it, so it's turning the fibroid white. So it's destroying the DNA of the fibroid. It's basically making it go from something that's as hard as a baseball to something that's mushy, like marshmallow, like something that's as strong as pork, but then you now make it, you put it in the oven for 24 hours and it becomes pulled pork. And then over time, it just kind of shrinks down and shrinks over 3 months, shrinks down and shrinks down and shrinks down. And so this particular treatment I was very excited about because, you know, for women who have the bulk, it's too big, it's pushing on things, we can shrink it down. And when you shrink it down like that and you kind of destroy the DNA, it cannot grow back. So unlike the myomectomy where we shave it off and microscopic cells can be left behind that can regrow the fibroid, we don't see that with the Sonata because it destroys the DNA. So no microscopic cells are left behind. And so this is for women who have heavy periods due to fibroids, so heavy bleeding, crazy abnormal bleeding, or pain because it's so big and it's making their periods very, very painful. Imagine the uterus is trying to have a period, it's kind of contracting. It's contracting against a tumor. Think of the uterus like it's a balloon and there's a tumor there and it's kind of squeezing against it. Makes it very painful. But when we shrink that, we shrink it down, then when the uterus is contracting, trying to have a period, the pain is not as severe. And over a period of 3 months, the fibroids shrink. We can go to the next slide, please.
I have a few Sonata questions that have popped up for
Yeah.
us. Does the Sonata treatment affect fertility in women of childbearing age?
So the uterus, remember, think of it like it's a balloon. The cavity, the inside of the uterus, the inside of the balloon is where the baby would be. So if you do the Sonata procedure and you avoid the inside of the cavity, then you can protect the inside of the cavity. That woman can safely still have a child. And so that's why we have our red and green zone. The green zone keeps you away from areas you don't want to burn. And so anytime you're approaching a fibroid, you make sure that your red zone is not touching the inside of the cavity where a baby would be. And so as long as you can do that, those uteruses or uteri can still go on to carry children.
Thank you. Is Sonata covered by insurance?
Yes. So what we do in our office, and the Sonata team have been amazing, where they would actually talk to your insurance for you. So my office staff don't even have to do that. So I just send a message that this patient is interested in the Sonata. They will call the insurance, get all the benefits, and then I will call the patient and say, this is how much your insurance is going to pay. This is how much you are going to pay. Do you want to proceed? So all that is cleared up before you even go into the operating.
Great. And one final question that's popped in is, if you have only subserosal, intramural, and pedunculated fibroids, and they're asymptomatic except for swelling in one leg, would you recommend removing the fibroid prior to pregnancy? And would the leg swelling eventually become a major issue in pregnancy if the fibroids are not removed first? None are submucosal.
Now, the question is, are those two things related? Is the leg swelling really related to the fibroid? Has the doctor confirmed that this fibroid is the reason that there is a leg swelling? Or is there something with the vein, something else responsible for the leg swelling? I try not to overpromise my patients because, you know, fibroids cause heavy bleeding and pain. they cause pelvic pressure. They're pushing on things. It can cause pelvic pressure. So is it possible for it to cause one-sided leg swelling? It's a possibility. Now, pedunculated fibroids, we cannot treat them with a Sonata. Remember, we need to have a safe zone. Pedunculated means it's hanging off a stalk. Tara, do you think we can go back to that slide that shows where the different types of fibroids? Almost there. It's like one of the first. So imagine a balloon, and then there's a stalk on the balloon, and then the fibroid is hanging off that stalk. So if I were to go after that fibroid, I'm not safely within the uterus. Now that is near bowel, that is near bladder. There's no way for me to get a safe zone to ablate that fibroid because it's free floating basically in the pelvis. It's not inside the body of the balloon. Perfect. One more. Perfect. Yes. So see how these intramural fibroids, or the fibroids in this picture, are kind of surrounded by the muscle of the uterus. So our red zone will cover that fibroid. The green zone will cover the muscle of the uterus. If it's on a stalk, then it's not covered by the muscle of the uterus, and I can't safely burn that fibroid because then that fibroid could be resting on bladder. It could be resting on bowels. So it is not appropriate for a pedunculated fibroid because I cannot get a safe zone on it. Subserosal depends on how subserosal it is, because if it's really, really, really on the edge, again, trying to get a safe zone. It needs to be surrounded by muscle of the uterus so I can get I can get the whole fibroid. Yes, just like this one. This is an intramural fibroid surrounded by muscle. So I can cover the entire fibroid and still have safe uterine muscle around it. Then I can burn the fibroid. The muscle around it is safe. And then I'm not outside the uterus touching the bladder or bowel. So it's best for submucosal. It's best for the fibroids that are inside the cavity of the uterus. It's best for intramural. So the ones that are surrounded by muscle, such that we can safely ablate the fibroid without damaging the uterus or anything outside of the uterus. What was the other part of that question? So I cannot speak to the leg swelling because I don't know that the fibroids are causing the leg swelling. I can only say that removing fibroids or shrinking fibroids before having children will be helpful, because guess what happens in pregnancy? Estrogen levels are exponentially high. Remember, the fibroids are fed by estrogen from the ovaries. When you're pregnant, the estrogen levels are just ridiculous. And so fibroids grow super big in pregnancy. They make your pregnancy higher risk. They can restrict the growth of the baby. They can make you need to have a C-section because they're in a location that won't allow the baby to come through. So they can kind of make pregnancy very, very distressing and uncomfortable, more uncomfortable than pregnancy is normal. So I would recommend treating them if possible before pregnancy. But depending on where they are, how big they are, it will depend on which treatment is the best. But as long as they're surrounded by muscle, we can safely ablate them with the Sonata procedure.
So I will go back to your other slide, and one question that came in is, Sonata almost sounds too good to be true. What are the long-term effects, doctor? Are there any longitudinal studies following women that went through this treatment?
Absolutely. So these women were followed for about 3 years. And there's a slide that will show that as well. They were followed for about 3 years. Their symptoms were still reduced at 3 years. They still had better quality of life than they did prior to the treatment. Again, it's about targeting the fibroid alone, destroying the DNA of the fibroid alone, shrinking the fibroid alone, and not touching anything else outside that. Like the surgery I just came out from, 5 centimeter fibroid, we were able to get a safe zone for about the top half of it. Whenever we got to the bottom half of it, the bladder was always coming through. And so I couldn't ablate, so I was able to ablate 3.6 centimeters of that fibroid. I couldn't get the whole 5 centimeters of that fibroid, and we tried. different angles is actually why I was late, because I was in that surgery longer than, you know, I usually am. Because I was trying different angles to try to see, can I get the rest of this fibroid? But every time I went in, the bladder would just kind of slide into my view. And so as long as you stay safe within the fibroid itself, you don't incorporate bladder, you don't incorporate bowel, your red zone, the red zone is what's ablated, is just covering the fibroid, then the laser energy is only directed into the fibroid, not even around the uterine muscle around it. And all you're destroying is the DNA of that fibroid. So I've had great results with it. The surgery itself is not as complicated as other surgeries that I've attempted in the past. And so it's easy to learn. So let's say it's a doctor who's trying to start this. It's actually easy to learn. You have good support. You can see your ultrasound pictures easily. You have an ultrasound sonographer there to kind of tell you, I agree with your seeing, doctor. And so it's definitely one I've enjoyed taking on and adding to my.
And what are the side effects of radio frequency waves or energy?
Radio frequency waves or energy, again, as long as you're targeting the tumor, you don't have any side effects to your uterus. It doesn't make your uterus weak, for example. So think about a myomectomy. When we make an incision in the uterus and take the fibroid out and then sew the uterus back up, we always tell our patients you can't get pregnant for 6 months, because now there's an incision in that uterus. If you now have a pregnancy that's making the uterus big, you could break open that scar on the uterus. So that's a disadvantage of a myomectomy. Now, and sometimes with a myomectomy, depending on where we do it, you might need to have a C-section. If I cut into the top of the uterus to get your fibroid out, and I cut really deep to get the fibroid out, then I don't want that scar, you know, I don't want a lot of stress put on that scar too much when you're pregnant. So I probably would deliver you at 36 weeks, because I don't want you to start having contractions and that scar breaks open. So there are treatments of fibroids that can make the uterus weak. But we don't see that with the Sonata. Again, we're targeting just the fibroid. And that's why I like my green zone and my red zone, because then I can, you know, be sure that I'm staying safe and protecting the integrity of the uterus. All right. Yeah, next slide, Tara. Oh, this is a patient I did about a month ago. Same picture as all the stories that we've heard, you know, heavy bleeding, soaking through her clothes, having to use a pad and a tampon. And so she just came for a regular checkup, an annual exam, pap smear, and we were talking about her periods. And she was describing it to me. I was like, well, that's not normal. Why don't we do an ultrasound and figure out what's going on? I did an ultrasound. There was a big 6-centimeter fibroid at the top of that uterus. And, you know, we talked about different treatment options. I talked to her about all the options that were listed there and the Sonata. She was like, oh, okay, I like that one. You know, I go home the same day. I go home the same day. I don't have any incisions on my belly. I don't have to take pain medicine. She didn't even take the ibuprofen I sent her. And so I called her the day of the surgery. She was like, oh, doc, I don't even feel like I had anything done. I just kind of feel sleepy from the anesthesia. Next slide, please. And hers maybe took an hour to do. It was just one singular fibroid. Oh, yeah, the video here is showing, sorry, Tara, go back to the previous slide. The video here is kind of showing the fibroid before the Sonata. So this big round guy here, hers was 6 centimeters, so like as big as a medium-sized orange, pretty large, you know. So that's what it looks like before we did the Sonata ablation. That's oh, Tara, go back to that picture. Do you see this little water-filled thing to the right? Yeah, that's the bladder. So that's how close the bladder can be if the fibroid is on this edge. Can you show the serosa, Tara? Kind of put your cursor near the serosa. Yeah. So if the fibroid is on that edge, it's going to be hard for me to burn that fibroid without incorporating the bladder in there. So that's why sometimes subserosal fibroids are not a good option. But if they're big enough, then we can get them up here in the center. Tara, kind of put your cursor by the center. Yeah. We can get them up there, but we might not get the edge because we're trying to stay safe. All right, next slide, please. Oh, sorry. Yeah, next slide. And so this is the fibroid after ablation. See how it's white? That's because it's been ablated. It's now mushy. And the mushiness kind of happens over time, but it's really nice to see the change from something solid to something turning pure white on ultrasound. That means it's been heated up. It's been heated up. And the procedure, like I said, took maybe an hour to do. I saw her 2 weeks later. She was feeling fantastic. And her periods are much lighter than it used to be. Not as dramatic as all the things that she used to experience beforehand. So I just wanted to share with you a real life patient of mine that I've treated. And that's what the fibroid looks like. So I was kind of doing an ultrasound after. You can see that round thing there, yeah. And it's all, yep, and it's all white. So that was how we knew that we had completed the procedure, because we had been able to turn the whole fibroid white. All right, next slide, please. Yes, the Sonata treatment is safe and effective. About over 8,000 women have been treated worldwide in US and in Europe. Multiple articles have been published showing the effectiveness and the safety of this particular procedure. I like it because you don't have any incisions. Your risk of injuring the bowel and bladder are low. And so, you know, it will make surgeons feel good about doing something about fibroids. Next slide, please. And someone asked this question earlier. This was the slide I alluded to. So in the trial, they followed 147 women for 3 years to see if their symptoms were sustained. You know, 50% were able to return to normal activity the next day. All my patients have been able to go back to normal activity the next day. 95% had a reduction of bleeding by 1 year. So remember, it kind of shrinks over a 3-month period. And so you gradually see a reduction in your flow, and more reduction by the time it's a year and that fibroid has really shrunk down. At 3 years, 94% of them were very happy with their treatment, with their results, and they were glad that they had the Sonata procedure done. And 88% said their symptoms even got better from when they first had the procedure done, so at 3 years.
And we had a question that came in. Have you had any successful pregnancy results after Sonata treatment?
So the Sonata, like I said, is kind of new to me. I just started doing this procedure this year. It's been available, I believe, since 2018, and you know, FDA approved. And there have been pregnancies reported, successful pregnancies reported. And whether it was C-section or vaginal delivery was not dictated by their history of a Sonata procedure, unlike a myomectomy way it would have been. Okay. Next slide, please. All right, so the Sonata is for fibroids causing heavy bleeding. Someone asked me if we could treat adenomyosis. You know, I had a video about it on TikTok, and I had a question of adenomyosis. Now, we don't have any studies on, adenomyosis. Sometimes adenomyosis is incorporated with the fibroid, and so treating the fibroid might also affect the adenomyosis and in turn make the bleeding less. But I can't definitively tell you that that's what it's for. So anybody who's currently pregnant obviously we don't want to introduce anything to the uterus if there is a baby inside the cavity. Remember, the probe, the wand, goes inside the cavity. So if it's a pregnancy there, we don't want to put anything in there. If someone has an infection, if someone has uterine cancer, we don't want to ablate any of that and spread that, right? If there's Escher, I don't know if anyone still has an Escher these days. That coil that goes into the tubes for tubal ligation, we can't, because it's metal and we're doing a laser radiofrequency ablation, we can't combine those. So anyone who has an Escher cannot have this done. If there's an IUD, we can just take it out. The IUD is plastic. We can just take that out to do the procedure. Safety and effectiveness with regard to fertility after the use of Sonata has not been established, but we have had women get pregnant after the Sonata procedure. Like I said, most people do really well after the surgery since there are no incisions. Maybe they have cramping, they take ibuprofen, that's about it. Next slide. Yes, if you would like to learn more about the Sonata procedure, I would love to talk to you about it. It's basically one of the first thing I offer my patients for treatment now. So you would either go to my website, didomedical.com, or you can text our office or call our office at that number that's on your screen, 708-340-1167. And also, one of the things that you can do is you can speak to a Sonata nurse. You know, they'll kind of get your details, they'll get your information, they'll get your symptoms, and they'll say, yeah, you're a good candidate. And then they'll find a doctor in your area. But if you're attending this webinar, you're probably in my area, so come and see me. And I'd love to evaluate you, do your ultrasound, do your evaluation, and see if Sonata is a good option for you. I did talk for an hour, didn't I?
And it was fantastic. Yes, we will send a follow-up email just so you all know with the information of the link and the text and email of how to schedule a consultation with her office so that you can do that today and get in there. I do have a few questions that I am getting in the chat. What type of imaging does the doctor need to make a treatment plan?
I start with an ultrasound. So if I can identify the fibroids on ultrasound, then, and I can tell, okay, this one is inside, this one is outside, this one is the size of a baseball, this one is, then we make treatment discussions right there. So I do the ultrasounds in my office myself, and so right after the ultrasound, we sit down, I draw the pictures of where your fibroids are, and then I tell you the different treatment options available for you. Sorry, I'm chuckling at one of the comments that just came in. Sometimes if you cannot visualize the fibroids really well, let's say they're super big and they're kind of jumping off my ultrasound screen, then I would get an MRI. And the MRI will help to say, okay, this is how big it is. This is top right, bottom left. So that's how MRI can help. But most of the time, all you need is an ultrasound.
Great. Natural remedies, we talked about that. I think we got all of the questions. Someone is on here from Sydney, if you could believe
How
it.
exciting.
Yes, which is very cool.
Yeah, I wonder if they saw one of the social media advertisements about the webinar. That's cool. Welcome. Thank you.
And
Canada. Wow. LinkedIn. Okay. They saw it on LinkedIn. That's cool.
nice.
Thank you. Thank you.
Well, thank you, Dr. Dorawade, for joining us today and sharing your information. It was very, very helpful and wonderful when we find physicians like you that are offering women the entire spectrum of fibroid treatment options and taking the time to speak with them about all of those options and figure out what's best for them. As I mentioned, we will absolutely be sharing the link and the number to text or call her office to schedule a consultation. And if you have any future questions, please send them in and we will be sure to get them over to her to be able to answer those.
Thank you, Tara, and thank you everyone for joining me today.
Thank you.
Thank you so much. That was amazing.
Thank you. Thank
Yeah,
you.
that was really fascinating. Thank you. Bye, guys. See ya.
All right. Bye-bye.